is, holding stitches for the septal incision area.
Take 1 or 2 stitches. Pull both down. Scissor. Any scissor. No, don't spoil this. So what we've done is we got the turbinates to be medialized. Okay?
Yeah.
But when this vicryl comes loose, I want the turbinate to come back lateral.
Yeah.
So that it opens up the olfactory area.
Hmm.
If you bulgarize it, you're jamming this area forever.
Yeah.
Yeah, I think. Yeah, may cut one meter. Stitch. Hold the light.
So this the stitch which you took for the middle turbinates and all this, do you remove it or it just like
Yeah,
dissolve?
so if you're using normal vicryl, it takes about 6 weeks.
Okay.
Little longer. No, not so long. Perfect. And I'll take one quilting in the septum. You have a speculum? Is it speculum? Self-retaining.
So do you take quilting sutures for all the septoplasty patients?
Yes. We're just going to have to wash and put some packs. Okay. Hold the thread. Long one. Okay. Okay, wash.
Nishit, are you addressing the inferior turbinate also?
No.
No. Okay. Posterior nasal nerve.
Sorry.
Posterior nasal nerves.
Take it out.
Posterior nasal neurectomy or cobbletting that area.
For what? Inferior turbinate?
No.
Wash. No, what was the question? I didn't hear.
No. Are you going to address posterior nasal nerve?
No,
Posterior nasal nerve.
I think
Nerve.
this patient doesn't need anything more to be done for the inferior turbinates.
Okay.
One more. Yes, thank you. Suction. So we're going to put in some sinus packs and the nasal packs. Packs are ready?
Packs are ready. Packing. Sorry.
Then you from Again. So these are 4 centimeter packs. And then we'll put in some nasal packs. Just hold the threads up. Thank you, everyone.
Thank you.
Light
Thank you,
off.
sir. Thank you for brief. So as we start for the next case, I'd like to request Dr. Prasad Kelkar to moderate the next case.
ले लो. Chalo, let the anesthetist come in. Drapes out. Drapes out. I'll do it. Done. बाहर अच्छा that's right. नाही तरी पण change the mask also.
Hello.
नाही I'm okay. आया हो गया. Shall we load the next patient scans? These minute है ना? You can do it on the computer. I can. On pen drive पे किस पे? Pen drive.
नाक बंद है, नाक बंद है, आपको मुंह से सांस नहीं है। ओके बात। और मैं लेंगे आपको बंद है।
Hello.
Take you through those scans. Give us 5 minutes.
Yeah. Nishit,
हाँ बोलो.
yeah, just wanted to ask regarding navigation. I mean, know little more about it. So I just want to know, do you use it for each and every case, or I mean, select the case for
For
navigation?
FES, generally we don't use navigation.
Yeah. Okay.
If I have a revision case, I might use it.
Okay.
Or if I have a difficult mucocele, papilloma,
Right.
something going lateral, frontal with
Right.
partition,
Right.
and we are not absolutely sure if we open the correct partition,
Yeah.
then I may use it.
Okay.
For skull base, again, any revision case and any extended endoscopic procedure,
Right.
or if it's a non-pneumatized sphenoid.
Okay. And how much time does it?
हमने पानी का
together.
Auditorium.
Hello.
Yeah, anyone's got a mic?
Yeah, yeah.
Okay. So, we're just showing you the scans for the next patient.
Yeah.
So, again, we're looking at coronal first. Let's look at left side. So, we have an interfrontal frontal. We have an interfrontal frontal.
Okay.
At this point, I'm not very sure that interfrontal is draining separately or opening into frontal. It looks like it may be draining separately.
Okay.
I'm not sure if you can see if there's a thin septum. This is the middle turbinate,
Okay. That's
small supraorbital starting off here. Agar
okay.
is not very clear on the scans. Unfortunately, I'm struggling to see from so close. But I think there is one cell up here
Yes.
which goes into the supraorbital. So I think we have an agar, a type
Yes.
1, a supraorbital, and then the frontal. But I can't be sure
Okay.
on the left. These bone cuts are the bone looks very faint here. So
Yeah.
that's middle turbinate. You have ethmoid. You have the uncinate process here.
Yes.
As we go further back, you have the anterior ethmoid artery running across here,
Okay.
reasonably close to skull base, so not very low. And then you have more ethmoid cells, start of the superior turbinate. And then, of course, it continues posteriorly. There's nothing much to see. We're coming now towards the sphenoid. So you have the sphenoid sinus, optic nerves.
That's the allergic fungus there in this posterior ethmoids.
So to see allergic fungus, we need to look at soft tissue. So when we look at the soft tissue in the maxilla, I'm not seeing double density.
Okay.
Okay?
Okay.
So I'm not sure. It looks more like just mucus.
Okay.
Mucus with polyps on the left. On the SAG, we see that in this patient, the frontal recess is not wide, as we
Yes.
saw in the other case.
Yes.
Much narrower one.
This is right frontal, no?
I'm assuming it's right. Let's see. No, this is, yeah, right frontal, very narrow.
Yeah.
Left is a little
better.
better.
Yes.
But again, I can't see partition very well. So maybe on the navigation machine, we might see it better. I don't know what else I can show you. There's only more pathology seen. I'm not seeing too much anatomy here.
In the posterior ethmoids in the coronal cuts bone window, I'm seeing some faint bone or double density.
Over here.
Yes. 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 What's that?
But that's cuts through the bone.
Okay. It's the osteotic bone, that means.
It's bone. Because some bone will be in a coronal plane. Orbital, yeah. Anterior ethmoid again pretty flush. Uncinate process looks medially rotated. So here, of course, you have the bigger problem here compared to the last case is you have a lot of polyp in the olfactory cleft.
Okay.
Okay, so I can't remove those polyps without damaging the olfaction permanently.
Okay.
So we'll see how to deal with those olfactory polyps when the time comes. Maybe if this patient's received steroids after the scan, then there is some hope.
Yeah. Sometimes you have polyps coming medial to the middle terminate in the axilla and the adjacent septum region. So how you deal with them?
Yeah, so this patient has that. So we'll see when we go in.
Okay.
It depends on where they are attached.
Okay.
Okay, so this looks similar to the last case, but a little more difficult in terms of extent of pathology and identifying landmarks. But we'll just see how it goes.
Okay.
Little bit of a deviation to the left. Let's see. Hopefully, we should be okay. So I'm going to do the left side. Dr. Nikam's going to do the right side.
Okay. So
Huh?
wanted to ask you a few questions regarding frontal,
Huh?
particularly in revision cases with the narrow sinus. I mean, how you take it? I mean, would you get prepared for modified Lothrop, or I mean, how you decide that this patient will do endoscopically, or you have to do some additional procedure
For which situation?
for revision frontal sinusitis? I mean, revision cases when you have a narrow frontal basis.
In revision sinus, it's very what I say, rare that we end up doing a Lothrop. You know, unless it's a there's a lot of disease in the lateral frontal
Okay.
and causing erosion maybe of the skull base or orbit. Otherwise, I don't see the need in regular CRS to do Lothrop.
Okay.
More likely, we'll do it with tumors and that sort of situation, especially like IPs and or there's fibrous dysplasia, thing like that. But just for plain sinusitis is not common. If you have a lot of what's it called, scarring and
Hmm.
closure of the frontal sinuses,
Hmm.
and then you know that.
Okay.
But just because it's a revision, we would not do Lothrop.
Okay.
Okay, Lothrop for in inflammatory disease
Hmm.
has a very high closure rate.
Okay.
When you're doing it for non-inflammatory disease,
Yeah, neoplastic means tumors.
then the Lothrop does beautifully well in staying open.
Okay.
So I would always want to be careful with inflammatory disease about Lothrop. Okay, leave it with you. I'm just going to wash up. Our patient's already induced. We've gone through the scan, so we'll just paint drip and come back.
Okay.
Right.
मी म्यूट आहे ना.
Hello. Can you explain the registration process?
First, there is a different types of probes. First, we have to do for registration. We have to use the registration probe.
Okay.
This is a registration probe.
Okay.
Then
Oh.
you have to keep that registration probe in the band patient tracker, and you have to see on the monitor whether it is successful or not. Then you have to start the registration.
काय करा, काय जेवणाचं बिवणाचं काही नाही ना.
Uh,
हा, निघायचं ना.
Press the switch and place the probe on either side of the eyeball, nose. You have to cover the bony landmarks.
So first is on the glabella.
हे पण टाकून देऊ. हे, bag.
Here is a line we are saying that minimum trace. Once it's full, then we have to stop. And this is a registration accuracy, which is 1.7 mm. And these are yellow are the marking that
So-
cover all means from the tip of the nose to the sphenoid sinus.
So how much is the maximum accuracy we can get?
Should be less than 2 mm. 2 mm is acceptable.
On the screen, you can see that the scans are covered with two types of sphere. One is green and yellow. So within anything within the green sphere is less than 1, and anything within the yellow sphere is less than 2 millimeters.
Okay.
हा, धीरे धीरे.
And you have to check with the landmarks like nasal tip, inner canthus, outer canthus.
Chalo, let's start. Same as last time.
हा, लिखतो मी. त्याच्यानंतर मारायचं.
Yeah, close the mouth. Not sterile. Did we give head eye last time? Or? Table is at the bottom, I think. Tables at the bottom. Just little head up.
Finish.
When you change the position while doing surgery, does this change the registration process again?
With EM, it should not. The head up. Bus. Thanks. We used to have that problem with the optical systems, but with EM, I don't think we have any issue with head movement.
Okay.
Hello, camera cable.
Do you give any antifungals before if you suspect AFRS?
No, only steroid.
Okay.
That's okay. Leave it. Take that.
And do you continue it
Leave
post-operatively?
it, leave it. If I feel that there has been very extensive fungus, some of it has been intramucosal, then I will give itraconazole post-op.
Okay.
But otherwise, in a routine situation, no.
Okay.
Take the suctions above. Suction and camera above. Sorry, below. Take the suctions above. Okay, so we're ready to start. If you have an endoscopic picture,
Yes. Yeah.
Right ones. So in the newer EM systems, the ones that we have, we don't need this headband. So nothing comes in our way here.
Okay.
Okay. So here, even though it didn't look so bad, we see that the DNS is significant.
Yes. Yeah. When you have such a polypoidal disease on the septum,
Yeah.
how you address it?
Yeah, I mean, this requires a septoplasty so you can see it better
Okay.
because it is more cobblestoning. So,
Yeah. Yeah. But sometimes you have prolapsing polyps in that region. So
yeah, let's see what this side shows. Maybe I do the right side. Yeah,
Oh,
this side is a
yeah,
lot
that's
better.
it. That is better. But still, you have polyps in the.
So these
cranium.
polyps which are very high, I will not touch.
Okay.
Okay.
Or
Only polyps which are in the inferior half
okay,
will take,
okay. What is the reason you don't touch them?
because there's olfaction. No? The
Sorry, we lost the picture.
उधर भी गया लाइट के खाली whole city is gone. Only our building or only our clinic area. Those guys are okay. Auditorium hotel is okay.
हाँ हाँ they were so
होटल का जनरेटर बैक हो गया
Ah, 15.
Hello.
Hello.
Yeah, we got the picture.
Yeah, you can hear me now.
Recording in progress.
Yes.
Okay. So sorry, our electricity went off.
Yes.
So we're going to come back to you in a minute. Okay, you have an endoscope picture?
Yeah.
Okay. Give me packing. I was just infiltrating the septum in the meantime.
Okay. So you will be doing septum first.
No, we'll do the right side.
Okay, that's little
The
roomy.
right side first, then we'll do the septum, then the left. Unless the electricity goes again. If it goes again, then I'll finish the septum of it. Okay, so we're going back to the right side. Okay,
Yes.
in middle turbinate, middle meatus function. The inferior turbinate we've already lateralized. And you see that turbinate is very medially rotated, right?
The uncinate.
Uncinate, sorry. Uncinate. Okay, this is the anterior part of the uncinate. So we have some part which we can still take out. Let's use a debrider. Yeah.
So irrigation is
So the rotated part I'll just take out because I cannot use a backbite or anything else. with this.
This is 50-degree blade.
This is a 40 blade backbiter. So we go in with the backbiter, clean water. Go in with a backbiter, we go beyond the uncinate, engage, staying in the inferior 1/3, upper 2/3 junction, and we take our cut. Okay?
Yeah. Any specific choice of the backbiter you have, or you use the
I
ostrom?
normally use a Toby's, not
Toby's.
the ostrom,
Yeah, yeah.
because just fine. So then once we are there, we can just go down, enter into the maxilla, and rotate their uncinate and inferior part of the uncinate out. Okay?
Yes.
Can even do it separately. Take out the bone separate from the periosteum. But and then we also rotate the upper part of the uncinate,
Yes.
and we can take that bone out. Once you've done that, we can go back to our debrider and finish off the uncinectomy. This is the agar.
Yes.
Okay, opening up the agar. It's all agar.
We lost the picture again. Audio visual.
Can you hear me?
Yeah.
Now, can you see me?
Yeah.
Okay.
Oh,
So, taking the inferior part of that.
yeah. Do you have a debrider blade with the tracker, or it's the routine blade? you are using?
Yeah. We have the debrider 0 with the tracker.
Okay, this is 40.
This is we are using right now 40. Okay. So, that's the bulla. Just taking a bit of the upper bulla. This side we thought we have an interfrontal and a front,
Yeah, yeah.
but wasn't sure because of the definition was not clear on the scan.
This side it's a narrow frontal recess, no?
It's a what? Narrow, yeah. So now my middle turbinate is well defined.
For the frontal, you'll be doing the intact bulla technique, or you'll be taking the bulla down first.
Well, I've partially removed open the bulla.
Okay,
I haven't opened it completely.
that's the halvar cell.
This is the maxilla. You have a little bit of tissue here. Give me a scissor.
We lost the
Okay.
picture.
You can drag it from while that's
No, I need an angle. That's not working.
not coming.
You got a picture?
Yes. Oh, we lost it again. Hello. Can you hear us?
So they have to log into Zoom again. On both sides. Okay.
You can see them.
Wonder how this works. Hello?
Coming. Now they can.
Hello, yeah, we are back on track.
Okay. So, just trimming that turbinate part,
Yes.
which was polypoidal. Maxilla is now open nicely.
Yeah.
The bulla is partly open. And we'll see what we can do about the frontal sinus now.
Yeah.
This might be the supraorbital.
Okay.
It's too low.
Mm.
And yet it's going deep and lateral. So very likely it's the supraorbital.
Okay.
Means just below it should be anti-ethmoid. And above it should be the frontal and the
Interfrontal.
okay. So let's explore
Yes.
this area.
What instrument would you like to use in this for exploration? Curette or frontal sinus curette?
We are going to use a ball seeker. Who's ball seeker? So,
Okay.
glare from that window now. Too much. Huh? Okay. Can I get now the ball probe? Okay, so let's see.
Yeah.
Medially into this area here.
That's the interfrontal sinus
I'm not
septal.
sure if I'm in the interfrontal or the frontal.
Okay.
The way I'm feeling, it feels more like interfrontal
Okay.
because I feel restricted place, not in a very wide place. If I go lateral, I feel I'm in the frontal. Okay?
Okay. So the frontal drainage pathway is pushed laterally by the interfrontal.
Where is that navigation? Let's check with navigation. That curved suction navigation.
Curved wala navigation करते हैं.
We get some mucus from there. More mucus here.
Do you have any experience of hydrodebrider?
Any
Experience of hydrodebrider?
hydrodebrider? No, I don't know what this is. We are going into what we think is the frontal sinus here. And navigation. Okay. You have a picture of the navigation.
Yeah.
Can you see I'm in the frontal?
Can you magnify the navigation picture?
You have a direct line?
Yeah.
Or you seeing me?
No.
The frontal sinus is just mucus.
Yeah.
Okay, we take the remaining mucus with a flush, and immediately you see the interfrontal. Very
Yeah.
clear
Yes, yes, very clear.
on navigation. Okay,
Yeah, that's the big interfrontal.
I mean, despite our poor bone imaging, we were still able to distinguish that the interfrontal is different from the frontal
Yeah.
and find it. So the navigation for me was just confirmation. But if I was lost, I would have gone back to navigation to see where I am. Okay. Now we can go to ethmoid. We are still with the 0. Let's go 0. Straight divider. Straight divider.
The navigation study.
Hmm. Yeah, this is better. The eyes were getting strained. Okay, so we're going to go back to a straight debrider, 0 suction. Straight suction. Okay, so now we're going to go ahead with the ethmoidectomy.
Yes.
So you can see it on the navigation as well. Because now we are using a navigated straight blade. Okay, I'm not going to look at the screen because I want to see my endoscopy image. But this is a mistake that sometimes people make, you know. Because you have this kind of thing, you tend to look more at the navigation screen than the endoscopy picture.
Yeah, yeah.
And that is dangerous. There's no way I want to look at black and white when I can look in color. Upward fossa, please. Okay, it's a little bit of tissue here, bone here. Block, no, partly. Lots of places there is this mucin, allergic mucin.
Yeah.
Maybe there was fungus earlier, but it's got dissolved with the steroids, or it was just allergic fungus, allergic mucin with
Okay.
polyps. Okay, so we know this is ground lamella, right?
Yes.
You can see it on the scan as well.
Yeah.
Oh, sorry, on the navigation.
On the navigation.
Now here we are going towards the frontal. So I'm going to be close to my anti-ethmoid at this point. Because I have it now, I feel like looking at it, you know. But otherwise I would not look at it. But I know this is my anti-ethmoid area. Okay, we'll come back there later. We'll finish our low ethmoidectomy first. No, it's not working. No? So we're gone through the ground lamella now. Superior turbinate here.
Yeah.
In this case, because we had polyps medially, we'll also be looking medially. So I won't bother too much with that.
Looking medially, do you feel that that will destabilize the turbinate?
Yeah, but I have polyps in this case. So if I don't have polyps, I won't do it. But if I have
Oh.
polyps, It's already destabilized. It's already pushed. You have some bone here. Some more bone here. Structure. Okay, so now we want to see the skull base, right?
Yeah.
I have some openings here. I have some openings here. I know my skull base slopes from superior to posterior. As I go from anterior to posterior, it goes superior to inferior. Okay, but let's stay low for now. My posterior ethmoid cells are always the bigger cells, right?
Yes.
Much easier to find skull base at the back. Ethmoid. Okay, so you see here,
Yeah.
I have a higher skull base here.
Yeah. There's
I
a
know
posterior
this cannot be
base.
skull base, right?
Yeah.
So
So
this anterior skull base has to be superior to the posterior skull base. Give me a ring to it. So now I'm just going to use a ring curette
okay.
to just explore that area. Okay. From here, and with the ring curette, I'm just going to come anterior. Okay, and fracture.
Okay.
Fracture. And my movement is inferior to superior. Exactly the same way that the skull base is.
Right.
It might. Give me another suction. The suction, if you can put a stillet and just clean it. Okay, so now we have skull base at the back.
Uh,
You can see clearly.
yes. Where is the
Okay.
superior turbinate?
Better when medially.
Okay.
We're not bothering with that now. Debrider. Okay. So now here we are good.
Yeah.
I seem to have some cell laterally suction near the orbital apex. Yeah, very good. So I feel there's more cell here, right?
Yes.
Because your orbit is here.
Yeah.
And as you go inferiorly, the orbit curves away.
Can we see that on navigation?
Yeah, let's see navigation. Debrider navigation.
Where navigation?
Give. Okay, you see that cell? On
Yes.
Navi?
It's quite. Yeah. We can see that cell close to the orbit.
Okay, this is an
Yes.
infraorbital apex cell.
Yes.
So we know that the orbit is going to curve away,
All right.
right? So therefore, I need to open up that cell which is there.
Yes.
I'm doing something I don't like to do, which is following the navigation. Okay. So give me an elevator. So I'd rather just probe with a thing, because even if I enter the orbit with this,
Yes.
I will have exposed a little fat. If I enter with the debrider, I will take away the fat. And in this area, my muscles are close to the
Lamina.
lamina. Okay.
Yeah, but I think navigation has helped to open this cell.
Sorry?
Navigation has helped to open this cell.
No, I
with
knew
more
there was
confidence.
a cell. I was showing it. Hello? Ethmoid. So, yeah, navigation will help you, of course. But you must also know or expect. Wait. That, so I keep saying this, your guys don't depend on navigation. You have to know how to read your scan properly. You have to know how to expect. You must know that your orbit is curving away. So if something's looking flat over there, it must be a cell. Cannot be anything else. Okay? Optic nerve. Okay. So is that posterior ethmoid or is that sphenoid?
Yeah.
What is it?
It's a sphenoid.
Sphenoid. Let's check now with the navigation. Okay?
Yes.
Bang in sphenoid. Chalo. Now we come back up. So we've done a low ethmoid. We come back up along this skull base that we've identified. Okay? We'll just finish off this last part till we reach the frontal sinus. Deep breath. Yeah, it's okay. So here we are close to skull base. You can see that on the scan. I just have a little bit of this soft tissue which I need to take out.
That's a supraorbital.
Yes, looks like. But the bread is not working. Current of 40.
पर ये देखो ना गुलाब से जंगल को ये एक दो चम्मच से तो नहीं खा रहा है
So we have somebody who is going to do ENT at a very young age. Being inspired here. Okay, supraorbital.
You have sometimes a very deep supraorbital and the polyps or allergic fungal sitting there. How you approach that?
You can go in with a debrider, but probably safer to do a flush if it's fungus. If it's polyps, then you have to debride. Okay, so interfrontal, frontal, and supraorbital. Okay, we look inside with a angle scope and see. Okay. So this patient is very different from the earlier patient in the sense that we managed to save all the mucosa.
Yes.
It wasn't really that badly stuck. So that one with the debrider when I was taking polyp was getting mucosa. Okay. Switching to 45. Maxilla, attach the 120 blade.
Yeah, regarding the posterior wall of posterior edge of the maxillary ostium opening,
Hmm.
do you open it every time or you preserve the
depends on the
mucosa in that
pathology.
area?
If there is like this, you see mucus and I need to get a clear view. This fungus AFS, we need to get a clear view. We'll take it. If it's just normal sinusitis, we don't need to do. Then we just do a good uncinectomy. Bro. Yeah, bro. So give me that screen.
You lost the picture.
What is it?
Enable.
Give me the normal one. What I was giving you.
Yeah.
You're fine. No, but unless we need for the frontal, we'll see.
This is 45 degree.
Yeah, 45, cloud suction. We are sorry about the interruption. We have excess electromagnetic energy in the OT. Release suction. No, this is electric.
Please not now, sir.
No, that's good.
Nine, sir. It is not 9. This one.
Change. Come on, don't wait. Connect. Connect this. टेबल मत हिलाना. We have a little bit of polypoidal tissue on top.
Yeah.
This side it's clear. If I have a divider, I can take that polyp. The 120.
I'm gonna make this.
I'm just going to take out that little polyp and then we are done on the right. So we're going to go back to the 120.
Do we have a 70?
Yeah, scope.
Yeah.
Yeah, we got. Okay, so that's my frontal sinus now. Open, clear. Okay.
Yeah. Okay.
You want to see with a 70 or okay with this?
70 will be better.
And then we go to 0 from here. इसके बाद 0. Dry patty. Oh, it's big clean. Patty नहीं है dry. Dry? Is dry? Okay, बाद में. Yeah, कांच साफ करते ना. Always clean with a cotton. Your gauze scratches the lens. Okay with a 70.
Yeah. That's
Okay.
Yeah.
You can see the light coming out of the head.
yeah. The partition between interfrontal and frontal.
We are going to leave it
Okay.
because both the sinuses are well opened. There is good mucosa.
Yeah.
I don't think it's required to try and do masti there. Chalo, packing. So I'm just going to pack this side. Then we have to do a septum and then finish the left side. Chalo, you have a headlight? Or give me this upper ka light. Give me this upper ka.
Like 2 minutes.
Okay.
There is a
So I'm just going to do a little bit of that septum anterior part with the headlight. Nice. Take it out. Take it out. Take out the light. वो हाँ टेक दैट अप और नहीं ये बटन लूज कर और इसको पूरा ऊपर ले ले एकदम ऊपर है ना टेक इट हायर नो गो मोर व्हाट इज द मिड पार्ट ऑफ दैट थिंग
It's fine.
जाएगा ऊपर और नहीं द होल लेंथ इज देयर ना ये लूज करा या हाँ गो अप हाँ बस not even so much halfway also would be okay yeah now see we get a better nine okay go full up okay okay हाँ thanks ऊपर का थोड़ा लूज कर Yes. Yeah, just turn it down a bit. Knife.
Number 2.
So what happens is now I have two hands. My other hand is pushing here, so I'm getting traction. That whole traction part I don't get with the endoscope.
And that's
What takes 10 minutes takes like 10 seconds here. Once we are in, then we can give them our endoscopy view. I think at the far back we are also okay. Down also we should be okay. Need to take out maybe this much part of the septum. Okay.
the blade.
When you have very high DNS and strong caudal dislocation, do you have any different steps for that?
If you have a caudal dislocation elevator, yeah, then your incision will come very anterior. And you'll elevate the
On both sides.
cartilage on both sides.
Yeah.
Hold the head. Right. Ethmoid. Cartilage is out. We'll take out a little bit of the bone, scissor.
Yeah. Hello.
Hmm. See there? Okay, we're almost done. Last bit, I think I need to take a little bit here. See there? Give me that luck. Okay, so I think a septoplasty is okay now. Okay, we got some space here to work. Elevator. मेरा हेडलाइट निकाल दो. Inferior turbinate lateralized. And we have the uncinate here. So let's just clear up the middle meatus so that we can see the uncinate better.
Oh, there's a turbinate.
Yeah, I know, by mistake I went there. Okay. Block. In the zero. Blade is blocked, we're just changing. Block. Our blade is getting blocked very quickly. Big point.
What suction you are using?
I don't know. Lin? No, you're asking suction machine.
Is it a central one or the any specific make?
It is a specific make. कौन सा machine? It's actually supposed to be a very good machine for liposuction. It should be very powerful. So there is some other issue somewhere else. I think with this electricity going in on off, otherwise the first case it was working very well. Now we are good again. So this part of the polyp is stuck to the middle turbinate.
Yeah. What is your concept about resection of the middle turbinate at the end of the procedure?
Whatever, if it's polypoidal, I'll take it. If it's not polypoidal, I'll never take it.
But do you feel is there any change in the recurrence rates or cavity healing when you remove the turbinate or when you keep the turbinate?
No. But I do know that doing a revision polyp surgery without a turbinate is a very difficult prospect. So if I want to do a revision, I want the middle turbinate. And the fact that we do a lot of revision surgeries in which the turbinates are removed, inferior, middle, it just confirms in my head that it doesn't make a difference. That removing the turbinate does not cause. And it's a little unfortunate because we see a lot of patients where the inferior turbinectomy is done and there are lots of cells in the skull base and orbit area. So the surgeon trying to compensate for not removing polyps or cells in the ethmoid by doing an inferior turbinectomy is not physiological, and a lot of patients will have an empty nose syndrome. Even if it's a small percentage, it's still a significant percentage. I have at least 3 patients who are on psychiatric treatment because of inferior turbinectomy.
Regarding inferior turbinectomy, I mean, do you feel that the removal of anterior end makes it empty nose, or I mean the anterior end of the middle turbinate, how important it is for empty nose?
Middle turbinate?
The inferior turbinate.
Yeah, so inferior turbinate, well, it's not common, as I say, but unfortunately, the amount of turbinectomies being done is so rampant that even that small percentage. Now, whether you take inferior, you take the whole part of the turbinate or just the anterior part, not working. May not matter. There are some patients with the whole turbinate gone who are okay, and some with the anterior part who are not okay. But by and large, I would say it's with the entire turbinate is removed. And you really have too much space in the nose. Okay, so I'm struggling here with suction. So I'm ending up doing an ethmoid bulla opening even before opening into the maxilla. So give me a speaker. Give me a speaker, please. So we have a little bit of the uncinate still intact. So let's just figure out the maxilla first. So this is my residual uncinate in the inferior aspect. This is the maxilla. This is a bit of the anterior part of the uncinate. And then we'll walk it up. Hello. Give me a 40 blade, please. It point. Take a second. Okay, looks like our suctions are good again. Prepared. Maxilla. Give me a scissor, please.
You can touch that. You can touch. There, may to listen, may to-
Okay, done. Give me a backbiter.
That's my turn.
This maxilla was quite full compared to the other side. This is the area for the agar. Bulla. Upward. So again, you're just taking the bulla. So you see, it's not necessary that I will always do an intact bulla. Okay, that is. So let's clear a little bit of this polyp and then we look for the frontal. Again, we'll try and stay close to the block. Torque suction. Patty. So if you want your blades to last longer, then you don't do what I am doing. You take out the bone pieces with a forceps and not with a debrider. If your blades are going to be disposable, so for me, most of the places I go, the blades are disposable. So once we use it for one patient, they will be thrown away. So then I'm going to try and maximize that blade by using it to cut the bone without worrying about its future life. So it just depends on what your thing is. Okay. Okay, so let's see again the frontal area. I have a little recess here, which may take me into frontal laterally. Okay,
Yeah. This side also he has an interfrontal sinus septal side.
apparently. Supraorbital. Okay, supraorbital.
Yeah.
Give me a 45 scope, please. Anti-ethmoid artery below me. Okay,
Yes.
this
Yes.
is anti-ethmoid artery.
Yeah.
What I'm touching. So you see, even with all this disease, almost always you should be able to identify the area for the anterior point. Even if the artery is flush with the skull base like it is here. Sure. Give me a 45 scope, please. We'll look up with a 45 scope. Hmm.
Navigation. Run.
Huh? Okay, supraorbital.
Can you show the navigation picture?
Yeah, navigation picture.
No, we are not seeing the navigation screen.
इस पे focus करो और audiovisual person has gone for lunch.
Yeah. Now we can see that.
Okay.
Can you put that navigation
See
with
the
endoscopic picture screen as a complete picture?
Yeah, that's what you have actually. Okay.
No. Yeah. Now we have nice
Here is
picture here in the
supraorbital.
auditorium. Yes. And keep like
You
this.
agree?
One. Yes.
Supraorbital.
Yes.
There's some mucin in there.
Yes.
This is frontal.
Yeah.
Okay?
Yes.
I'm deep in the frontal. I'm not seeing any of that small cell, but
And where is the interfrontal sinus septal cell?
give me a seeker. Let's look for it. Seeker. आप दूर मत जाओ प्लीज आप ट्रॉली इधर ही रखो So I'm not able to palpate anything else.
Okay. But was that cell seen on a CT?
Yeah. Okay, I mean,
Yeah.
there was a small cell partition there, bony partition. Okay. Give suction, please. Yeah, release.
Is that a 70 scope or a 45?
We're on 45.
Yeah, that's
Okay.
yes.
In that
Perfect.
cell.
Yes. Yeah.
It was important to open it only because there's mucus in it.
Yes.
Okay, but now you can see it as well.
Yeah.
Okay?
Yes.
Okay, there's a little bit of bony partition there. If we can just break.
Can giraffe take out that?
Yeah, give me a giraffe. Give me a debrider. Debrider also. Give me a giraffe. Maybe your idea was better. Giraffe, horizontal. Okay, so it's not on the table. Give me upward. Action. Horizontal. Okay. Okay, so I think we are very good now.
Yeah, that's a big cell.
Yeah.
Side to side giraffe will take out that. Or RAD 120.
No, we need the horizontal.
Yes, so there is a.
Hold this.
Side to side.
Doesn't close fully. Okay, I think big enough opening now.
Yeah.
We don't need to bother more. So frontal done, supraorbital done, interfrontal done. Let's go back to ethmoid. Straight 0, 0. Straight suction.
Yes, yes.
Give right straight. Mm. Straight suction first.
Right.
So here we got a very nice clean skull base.
Yeah, yeah.
There are no polyps attached here.
Yes.
So that's good. So when you see something like this, you're a little more hopeful in the post-op time that the patient will not have recurrence as compared to the first patient who had everything stuck to the skull base.
When you have such a huge polypoidal mucosa, I mean, do your follow-ups change, or you have any different follow-up strategies for patients whom you suspect that there is a high chance of recurrence?
This patient should ideally get a little bit of steroid, oral steroid post-op,
Okay.
and then it's a little strange. Sometimes you have sinus patients who get reactive polyps post-op,
Yes. Yes.
and very bad polyp patients who do beautifully
Beautiful.
post-op.
Right. Right.
So I'm not sure. You do what you need to do, and then you take it visit at a time.
Okay. So,
This is a orbital apex. Okay?
what is your take on the immunotherapy and allergy testing for such patients?
So we've had now a few patients of recurrence,
Okay.
of bad recurrence. I
Okay.
think a couple of patients straight suction, who we operated twice already and have come back again.
Yeah.
And we've sent those to Dr. Sunita,
Yeah.
who's our allergy girl in Mumbai,
Yeah.
and she's been using omalizumab, I
Okay.
think,
Anti-IG.
and she got some fantastic results.
Yeah, but omalizumab has to be given on a once a month injection.
Yes, she gives I think 3 injections.
Yeah, but I mean that again. I mean you have to give on long-term basis. Till the omalizumab is given, patient is absolutely fine.
Yeah, so we don't know now what will happen long term.
So
We are not doing it as primary treatment. We're doing it for recurrence. At least patient gets off your neck for some time. Then we'll see long term what happens.
yeah, and
Give me a elevator, some polish, pneumonia. Yeah. And what?
yeah, the omalizumab is not actually approved by FDA for the use in polyposis and allergic rhinitis.
Yeah, we have dupes, but we don't have dupes in India.
Yeah.
So we use it. Okay. Orbital apex. Sorry, optic
Oh,
nerve.
the sphenoid.
Optic nerve, sphenoid, yeah. Yeah. Give me a ethmoid, please.
What about immunotherapy? I mean, do you feel that it makes a difference?
I'm not so sure about that.
Okay.
Though the allergologists claim very good results,
Okay.
I find that only some patients do well.
Okay.
The bigger problem is compliance. Because to take that twice a week thing for few years and not get fed up, I think you need a very determined patient to be compliant with immunotherapy.
Right.
Whereas most people are not.
Right. But do you subject all such patients for allergy testing immunotherapy, or you select few? I mean,
No,
those
not.
no.
I think it would be a good idea to do IgE and PFT for all patients.
Yeah.
But practically speaking, it doesn't happen.
Okay.
Give me a point again. Okay, so that's the end of our sphenoid business. We'll just have a quick look at anything remaining. Take 2 stitches on the septum and then we are done.
The same treatment.
Okay, skull base,
Yes.
ethmoid again.
Any topical steroids you use now?
Yeah, I mean on table, I think the anesthetist has given some Decadron.
The topical.
Topical? Oh. No, I haven't got much experience with that. What about you?
We used to do it initially with the triamcinolone, but somehow most of it goes down into the nasopharynx, and I don't know how it works.
No. So one option is with the nasal pack, sinus pack, you can soak it with steroid instead of water. At least for 2 days it will work.
Yeah. Sometimes we do a very good job.
Do you have any bipolar or any coagulation? Bipolar, monopolar, chalega. Whatever. Okay, so we just take 2 stitches. Give me a Vicryl.
Just wanted to ask you the connection between the middle turbinate and the lamina papricia, the horizontal. This you have kept.
Yeah, we always keep it.
Do you feel that keeping that connection, the turbinate gets lateralized?
If you keep this, no.
If you
If you
keep
take
this,
this out, it becomes very floppy. There's more chance of it lateralizing if you don't have this.
Okay.
On
1 second.
Because sometimes you have cells behind that which remain when you keep this horizontal partition.
on. I'll tell you what I do. 1 minute.
Okay.
Just trying to stop on bleeding. On. 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 Off. So when you look at the nose,
Yeah.
you're looking at the middle turbinate, you're seeing this inferior part, okay?
Right.
I'll need that bipolar again. So you see, I'm seeing where the level is. Then I'm looking here and seeing if my level is close to this level. then I know I have no cell left.
Okay.
If I'm seeing the sphenoid as well as this, I have no cell left. I'm not seeing any bumps here, I have no cell left.
Okay. The inferior part.
Yeah, there are a couple of ways to do that now. Give that bipolar.
Show that
On.
with navigation.
Off. On, off. Navigation. Any navigation.
Here this.
No, deep navigation, okay.
This program.
No, straight. Acha, there.
You can just use it directly without the device.
Okay, good.
Just like it.
Is it working? Okay. That's my ground lamella bottom. You see it on the side.
No, I mean we are not getting the navigation picture. Can you get a full navigation picture? Audio visual.
I'm going to make the final print.
Okay.
Yeah. That cell.
See as I come out,
Okay.
where the bottom of the ethmoid.
Yeah.
Everywhere we are bottom of ethmoid. We're walking into sphenoid.
Okay. Okay.
Hello, stitch.
Okay. Great.
We'll take some septal sutures and we'll put the back. Yes. I'll run. I'll just take middle turbinate stitch and go. We're just going to take our turbinate stitch.
This turbinate stitch is easy when you have a thin turbinate. I mean, do you feel then any problem when you have a thicker turbinate? Because it looks very easy when you do it, but when I try to do it somehow.
Yeah, it takes a little getting used to.
Yeah. Yeah. When you have a turbinate like this, no, the
In
big
the
one.
beginning, it's not very easy. But then once you get used to it, it's not difficult. Also, I'll tell you, hold this. So when you go in now, you hold your needle very loose.
Yeah.
Okay, very loose, and allow it to drop. See how I'm holding it, okay? I'm
Yeah,
holding
yeah.
it parallel.
Yeah.
Then I can turn my wrist and just go in like that.
Yeah.
This trick actually Dr. Kirtan taught me. Right? Also. Boom. A little relax on the lower one. The lower one, little relax. Huh. We got all 11 instruments. No, give me the upper part. Yeah. Yeah, I'm very close here. Pull your side, both scissor. Scissor strong. Okay, thank you everyone. Acha. We made it. Thank you, ma'am. Thank you.
Thank you. It was a great
Thank you.
demonstration. Thank you very much.
Thank you. Okay. What's the time? Yeah, so our luggage is in the hotel. Yeah, so we'll run to the hotel, pick up our bags, have a quick lunch. And leave. एक केस हो गया एक केस हुआ लेफ्ट साइड राइट साइड are two separate cases plus two septums. खोल लेना है एक और वेरी attached. Thanks. Audiovisual, mic, audiovisual. मेरा माइक कौन लेगा? Yes. Your transportation है कुछ? क्या है?
एका सिटी स्कॅन
Chapter Chopran, HL Chopran. Adu, केलं registration. endoscope camera system. Endoscope camera.
The next camera on the
नाही ते नंतर ते मध्ये सांगतो मी आता कोणीच नाही तिथं. झालं सुरू. काय ठीक आहे चला पुढे.
दीपक पॅटेचं सोल्युशन
घेतले सर टाकले सर टाकले
लावलाय. Good afternoon.
Hello.
Yeah.
Yeah. Good afternoon, Mahesh. Rishika here.
Yes, Rishika just started doing the packing. We will go through the city.
Yeah. There seems to be a DNS on the website.
When I can negotiate my scope, so I will do septoplasty afterwards.
Okay. This is okay. You're showing us the CT scan, right?
Yes, if you go through the coronal plane, frontal, interfrontal.
Just a minute, Mahesh. We are not focused yet. Can the camera person focus more on the city things? Bit more zoom in. Yeah. Yeah.
थोडा अजून जवळ. हा, अजून. If you see the right side, there is a interfrontal cell.
Yeah.
That is means type 4 frontal cell.
Yeah.
That is totally in the frontal sinus.
Yeah.
Okay. Then supraorbital cells are there.
Yes.
Right side more, left side less. Then the if you see the anterethmoidal artery,
Yeah, which is a dehiscent here.
yeah, dehiscent or it's not uh, attached to the skull base. There is some cells over it, so we have to be careful while dealing with it. Then the one more thing we see here, there is a boginess of maxillary sinus on left side.
Yeah.
Ah. So while entering the maxillary sinus, we have to see because of also that may be the reason the patient complaining of nasal blockage. Then we have a posterior model cells, so many model cells, and then we have a lateral races on right side.
Yeah.
That is yeah,
Swanberg's canal, they say.
yes, yes. Frontal, if you see the frontal races, we have wide frontal opening on right side also and left side also. That is sufficient.
We have an interfrontal cell on the right side, right?
Yeah, right side. That is totally in the frontal line. So and it is clear. So we
So
don't.
we might.
Yeah, there is a only mucosal thickening at the base of the frontal sinus. So it's a simple thing to debride or just if you pack it, then it will be subside. It get this decongested.
So you are also using the similar solution what Sir had used, that is 4% with 4 ampules of adrenaline.
Yes, yes, for nasal packing.
And do you infiltrate the nasal this, or you just prefer packing?
I just prefer packing. I never use infiltration for endoscopic sinus surgery.
And how you prepare the patients pre-operatively?
Same way, steroid. We start steroid, antihistaminic, nasal spray, antibiotic also.
So what is your choice of steroid?
I use Predmate,
Red.
methylprednisolone. I use.
And so,
We have lost your.
we have speaker is online. He's doctor.
Mahesh, we have lost your picture. Just
Yeah,
yeah, we are back.
yeah. These are all polyps, so we have to debulk it. Then I will proceed. This is on right side.
Yeah. You have bulky.
Yeah. This is actually uncinate process.
Yes.
Yeah. That get polypoidal actually.
Yeah.
This is middle turbinate. So I will just take some tissue for biopsy. Suction घे, काम करतो. Straight blade लावलं. हा. याचं blade. Navigation blade.
डबी व्यवस्थित टाकून ठेवा.
ठीक है. I am more comfortable with debrider while debulking the
Middle
uh,
meatus.
yeah than the forceps.
Since you both are have done a bit of immunology courses in the biopsy which you sent for the histopath in the allergic fungal rhinosinusitis, is there any perspective which you would want to look from the immunological point of view?
Uh, I asked them to look for the eosinophil count.
Okay.
That will give me an idea about the symptoms, means how allergic it is. And for fungal IP also.
Fungal, I didn't get it.
Yeah.
IP.
This is unseen process actually.
नहीं सर वैसे पूरा पॉलीपॉइड ही था पॉलीपॉइड just took the biopsy from that point and we just started it. He's doing
Hi Mahesh.
Hello.
Yeah, this is Dr. Lele. And you are not going to do a proper uncinectomy and then proceed. You're just dividing it.
I'm just debulking the polypoidal tissue.
Okay.
This is bulla, this is uncinate process. So I have to enter the maxillary sinus from here. I usually enter through lower side.
Mahesh,
Yes.
Is this a image one system or a spice system?
Image one system.
Okay.
On this side also, I will debulk the polyp. Figure.
Why are you cutting this polyp?
For biopsy purpose.
Do you biopsy every polyp?
I used to.
चलो कोई नहीं जो बंदे और भी नहीं मतलब तू कितना मतलब दो बंदे ले गया उसको दूसरा बंदा भी दीजिए अब मैं वो अपने जो कर मेरी
महेश
Yes, sir.
श्रिया बोलते
नहीं
तिकडे जे कोणी कंट्रोल करतंय ना ऍडमिन तर
Yes.
त्यांना सांग की तुझ्या स्क्रीनच्या इथे पिन म्हणून करायला अदरवाईज ना हे बाकीचे जे बोलतात त्यांचे आवाज खूप डिस्टर्ब होईल आणि सगळ्यांनाच म्यूट करायला
एक दफा दोस्त होता ना सारे के साथ फिर एक दो दफा रिवाइज करते तो चीजें मैं वहां ही कर जाती अब वो देख नहीं सकता रहा तो
ऍडमिन प्लीज म्यूट टॉकिंग कोण चंद्रशेखर
सगळ्यांना म्यूट करून टाका रूम मीटिंग समजा त्यातनं आवाज येतच नाही.
this side also uncinate is
This
yours.
is unsafe
Yeah.
process.
Mahesh, tell us about some protocol of yours in patients with allergic rhinitis and this polyposis, allergic rhinitis and deviated nasal septum. What you generally prefer, whether you want to treat their allergy first and then to deal with the static obstructions?
No, if the patient having polyps like this, so better to operate. Pre-operative, I used to give them some steroid spray, and I usually preferred Gelanity in my sinus patient, allergy patient, nasal irrigation. I just,
what exact protocol means? You operated a face in such cases. So after how many days you advise them for an allergy testing or like immunotherapy afterwards?
allergy testing as soon as my antihistaminic stop. After 5 days, I advise them to do the allergy testing. And the patient having severe allergy, then I advise them to start immunotherapy also. I have so many patients for immunotherapy.
almost more than 40 patients. मला बोलतो ना, बोलतोय.
लागणार आहे. 15
So how is their long-term follow-up?
For immunotherapy,
Yeah.
Immunotherapy, I just started 2.5 years, since 2.5 years. And most of the patient on booster dose now.
Okay.
And most of the patient actually on allergy testing, we found that they have a dust allergy. They're all secretion from maxillary sinus.
So, Ritesh, we have been doing allergy testing now for many, many years, and we have had some very wonderful experiences. Patients do benefit a lot with that. Yeah, but I mean, unless you can really pinpoint some severe allergies, it doesn't work. But if you cannot, then the generally, those 3+4, those may not be that.
We are also doing in our center since last 3 years. So what we have experienced, those patients who are they are almost a 50% group is not so much benefited in a primary dose. They get little bit better in a booster dose that we give after 3.5 months to 4.5 months. And generally after 1 year, they are quite good compared to their symptom scores and all the.
Yeah, most of the patient doesn't need any antihistaminic or steroid free also.
Means they are literally happy. They say that their symptoms, considering their previous experiences, they are quite good without medicines.
And when do you, in your experience, when are you repeating the immunotherapy? So, because what we are seeing is every 3 years or so, they again need doses.
We generally, primarily we counsel them that this treatment is going to take 1.5 years. So you have to take that. Otherwise, you don't enter into this cycle of treatment, because if you ask us after a month or 2 months that this is not getting any relief or not getting benefited, so that is not going to work. And invariably, we offer them a booster dose. Previously, we used to recheck again those allergens which are positive in primary case, but nowadays we are directly giving them a booster dose of the same allergens.
So when you recheck, what you see a difference?
Yeah, there is a difference, but that is not comparing to the our ideal things. They are like +5 is gone down into +2 or +3, like that,
which is significant.
Yeah.
We have never done that. We have never rechecked with the things.
After completion of primary dose, within 8 days we generally check that.
Okay.
Only positive ones, not among all.
It's a good idea. We should do that.
Yes.
And it is good for us also to know whether which are getting deleted or which are getting resistant type, that they are not at all responded.
Yes.
Booster we have to give them. Mahesh, what is your take? What is your opinion?
I will start doing that, what you told us, because we usually not doing what you are doing. And how long you advise the immunotherapy?
Mahesh, initially for first 100 patients, we were not sure that this thing is going to work or not. So we initially counseled them that you have to take a primary dose, and you come for a follow-up, we will recheck and then we will decide whether you will need a booster dose or not. But these patients are, fortunately, 80% of the patients, they did well in a primary dose.
Okay.
For those patients who are resistant or who are not getting benefited, we are offering all of them a booster dose. But fortunately, good thing about this immunotherapy is that there are very less number of defaulters.
Okay. The compliance is important in every treatment.
Yes.
We have our set of defaulters. They take this. They take the vaccines and never take it.
Fantastic.
Mahesh, you need not to be over promising in these allergy patients.
Yeah,
You have to
okay.
be straightforward and clear to these patients, because we have almost a 20 to 25 patients who are having a severe category of allergic rhinitis with bronchial asthma. So these patients may take a little longer time, or they are not benefited with primary or booster dose also.
Okay. This is another side, maxillary sinus.
Okay. So this is what you were saying, that there is
Yeah.
a bulkiness over here.
Yes, this is the wall of
Yeah.
maxillary. Yeah, that's allowed.
Mahesh, you got the debrider blade with navigation probe,
Yeah.
no?
That is straight blade. I will use that after.
Why are you not removing that uncinate remnant?
Yeah, I will. Backward biting. Hmm. Ball
I
point.
think inferiorly that is gone now.
Pardon, sir?
Inferiorly, your uncinate is now gone.
Yes, sir.
So, yeah, that's the one.
You're right. Next.
Here. Agaricin, no?
Yes, agar is there.
Sir? Hello.
Yes.
Do you ask your radiologist to do some specific parameters for the CT scan settings and all that? For
For
basic.
navigation, we have to 0.5 mm cut, 0.5 to 1 mm cut, we should ask them. And axial cut, we require actually continuous axial cut. And we have to cover the specific area that from the actually from just above the nasion, from this side to cover the frontal and to the maxilla, upper maxilla. that window should be covered.
Have you ever seen some disparity between the radiological findings and at actual your navigation findings? If you put a probe in the, say, sphenoid sinus or sphenoid ostium, and
Till now, almost 25-30 cases, I don't see anything such. आम्हाला हे लावून स्पीकर ट्रॅकर then I just looking for frontal sinus now. Yes, speaker. Yeah.
Can we also see the navigation window here now?
Yeah. नाही हे लावलेली आहे ना लावली किती
did you get any problem during registration and all that mapping?
The thing is your trolley should be away while registration, because that anything metal can cause registration problem. So we have to take care of that.
So have you changed your table?
Yeah, I changed, but that doesn't help me.
Okay.
Does a table give
I
give a problem?
changed to, yeah.
Table will also give a problem?
Yes, sir.
The endoscopy
Table-
picture is lost now. Yeah, we got it now.
So this, I have to go through medially.
The navigation, if you can show us.
Navigation गेला. हे चालू आहे ते आहे मध्ये सक्शन पर सक्शन अपवर्ड सक्शन I'm more comfortable doing frontal with 70 degree. This 70 degree. So wash होना है. What about this?
So the navigation seems to just go off. Huh?
Yeah. We must know the CT scan beforehand. It just helps.
We are
It's
not,
a helping
we are not seeing,
tool.
we are not seeing the navigation picture here, and the audience wants to see it as you're doing the front.
Yeah. Frontal suction. Frontal suction. माझं suction. याच्यातलं बारीक कुठे जाऊ दे. आता कोणतं हा किती राहू राहू probe दाखव.
Verify करा.
पुन्हा
Front down.
झालं का? हे इकडे करतो का थोडस वरच्या साईडला? व्हेरी okay. This going into the interfrontal. Sorry.
So if you define the agar-nasal boundaries properly,
This is in frontal sinus. Dissection. There is a polypedal mucosa at the frontal recess. So I have to remove that.
so is this a 40 rad or a 60 rad or what?
It's a 40 rad, sir.
40 rad. So I think it's a very nice thing to see for the juniors. I don't know if there are any juniors here. So that see the debrider blade is putting it very nicely above the scope. So your entire field is in vision, and you can actually see the window of the debrider blade very nicely seen under vision, which is very important. It's a technique to pass it over the scope. So you initially long or under and then pass it over. So that switch you do as you go, and that is it's actually something you need to learn. Do it nicely.
Now the frontal sinus is able to see the debrider 40.
So Mahesh, before you start, do you cross-check that the registration is correct and it is actually showing?
Yes, sir. Yes, sir.
So what are the points that you check?
Tip of the nose, then inner canthus. We usually check over there.
No, inside the nose, you don't check. I mean,
Inside the nose, middle turbinate usually I check. I will clean some more mucosa over there.
Yes.
And this is a frontal sinus.
Yes, yes. There's some bone fragments still there.
Yeah.
Alignment. इथं इंजिन काय राहतं? Ready?
upward, Jira. Patty. Keeping the patty to achieve the hemostasis, then we will come again.
Field is not bad. You could
Yeah.
continue actually.
मग काय म्हणतात निवांत पावसाचं वातावरण हा लेट झालं होतं लेट झालं होतं
This third front. Navigation. This is this side frontal panel. You are getting navigation picture.
Yes, we are getting it.
There is a minimal mucosal thickening over here, but I have to widen that side. This is a bulla, this is a suprabullar cell on this side. We will delineate all the things. I used to come from behind forward. So I will start using 0 degree and start opening anterior posterior ethmoid, sphenoid, and then I will come back to frontal sinus.
Yes, that is always a better thing to do. Posterior to anterior. Actually, if you have a very vascular kind of sinusitis, it saves you a lot of time also.
Actually. First is important. This is a bulla. Advocacy. आता ते डिब्रायडर स्टेट डिब्रायडर लावलं. झालं. I am using navigation bed.
Okay.
block cut. This is a lamina. We have to get rid of this tissue also. The aim of the surgery is to widen the all the remove the polyp from all sinus and widen from the lateral wall of the middle wall of the maxilla to the middle turbinate. So you can visualize all the sinus. One like it, Baker's. Don't want to keep any septation. That's all on top.
So there's one question from the audience that
Yeah.
can you demonstrate the anti-rheumatic position now with your navigation, help of your
Okay.
navigation?
Ball probe. Let me see.
So when you take an instrument, you have to register it every time.
Yeah, every time. Sir. If you do not use the another one,
Then the same one will work.
yeah, the same one. If you use another one. और वायर तक ऐसे कपक बोलते हैं पूरे ट्रॉली इधर वाइट हॉस्पिटल बोला काय झालं We have to delineate the skull base, sir. Then I will show at the after some time.
Okay.
क्लीन कर पाता तो दूसरा भी देखता हूँ suction. I just enter the ground lamella to the posterior motor cells. Keep it right. Here the superior turbinate will come. Just delineating the sphenoidal ray. For junior people, while opening the sphenoid sinus, this is a good landmark. This
Posterior
One
wall of
is-
maxilla is in line with the anterior wall of sphenoid.
yeah, that is one thing, and also it is a 1 to, if you go medially, it's 1 to 1.5 centimeter above the choana.
The natural ostium.
Yeah. But always try to open from medially with the help of the choana. That is a safer side. open the spinard channel.
One of the problems going this way is that when you try to do it this way, the middle turbinate can become a little unstable because you can cause a lateral fracture of the middle turbinate.
Yes.
Also, the superior limit of the maxillary sinus is a good guide for where
Yeah.
your sphenoid sinus opening is going to be there. And generally, your sphenoid sinus ostium will be below that.
Yeah.
The superior limit of your maxillary sinus.
Because upward. Upper vacancy. Back please. I will go on either side. Open the spinard. This side middle turbinate is hypermobile actually.
I think it doesn't have much of a bone remaining,
Hmm.
but it's not floppy. It's not going to
Actually-
fall in.
It's all because of pressure, I think so. Pressure of middle wall of maxilla.
Yeah, it seems okay, but you have to see what happens when you knock off all that tissue.
Yeah.
So, Mahesh, if you add a little irrigation to this, no, that also helps a lot.
Okay.
I mean, if somebody, if your assistant can just with a little bit of saline keep on irrigating,
Okay.
so all this little blood that you see gets diluted a lot. Your debrider blade also doesn't get blocked often. Yeah, and just drop by drop, it doesn't. You should not flood the screen also, and so less number of times you have to remove your scope.
Yeah.
Yeah, so, and overall you finish your job much faster.
Yeah. We are able to see the free air cells posteriorly.
Yes, 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 definitely.
That is free of disease. Osh. नको नको करू. Okay, that's very. There is one cell here. Right. Yes. I am almost at sphenoid on that side. Action, please.
Mahesh, I think a picture, if just can you just try to focus a little bit?
Okay, sir.
I think थोड़ा focus off है.
Better?
No, what is happening is that you're focusing from far away, and when you're operating, you're going close. So yeah, now you do it.
Okay. Action.
I do it outside.
Okay.
Have you zoomed in much?
No, sir.
No. Okay. So just do the focus on that outside. Yeah. The Savlon gauze, that's the best thing to focus on. No, your lens is not clean.
Hmm.
Sometimes that also causes that slight defocus thing. I think you need to focus.
Okay.
No, little more. The picture is clear but not sharp. No, little. It's still not focused.
I think that is the AV problem, sir, because we have good picture over here.
Yeah. Okay. I think that seems to be the transmission problem. But picture is overall quite good. No problem. Just continue. Don't worry.
Okay. I am in frontal sinus.
Yes.
Wow.
Sign.
Yeah. मला हे, नाही. Out आहे, patient out आहे. बन पंचावत मशरूम दे. I will just widen the sphenoid ostium.
Yes. So. curate, straight curate also is a very good idea to delineate the skull base. Uh, Mahesh, can you hear us? Okay, we can't hear you at all. Huh? Uh, your voice is not reaching us at all. We can just see that Tech 2 is talking, whoever Tech 2 is. But it's me, sorry. We could just hear. We could
Hello?
hear. Yes, yes, we can hear you now.
Okay. Uh, this is a anti-wraith model. Are you able to see?
Yes.
This is the
we can see.
anterior wraith model from the left side. You see?
No, I don't think so.
Yeah.
I
This one.
don't think so.
No, this is anteriorly actually.
Ah.
Yeah, this one. This one.
You're
Yeah,
still not at the skull base.
I will just show.
No,
This
just
one.
just hold it steady there. Hold it steady there.
Yeah, this
So,
one.
yeah.
This one.
Where is your frontal sinus? Yeah, but on the video screen.
Frontal is here, sir.
Correct. So there is still some tissue there, which
And
you,
this is a anti-wraith mode.
is possible. Yes.
Yeah, that is only.
Yes.
This one.
That navigation screen we're not seeing.
Not okay.
Yeah, we're seeing it now. Now we are seeing, yes, we can see the origin at the beak.
Yeah,
Yes,
and
yes. Now we can see it.
on this side, this is, you can see from the,
But Mahesh, what I want you to do is, hold it absolutely steady at the point where it enters the orbit. Okay, now let's compare whether you're seeing a perfect picture.
yeah, okay. See, sir.
Okay, that is see. Now on the sagittal picture, sagittal part of that thing, it is seen way below the skull base.
Yeah.
But yeah, I think that's.
Yeah,
I think it's a fair thing. Fair thing. I
Yeah,
think that's. Yeah, there is a cell above it. So
Yeah.
yeah. It's seen.
There is
Yes,
a
yes,
cell of orbital cell.
yes,
why-
yes.
Yeah. Yeah.
On the right side, Mahesh,
Yes.
just show us once again. Yeah.
This one.
हाँ थोड़ा मागे नहीं आज जा
Oh, one.
बोल साइड
Yeah, ma'am.
हाँ just slightly go posteriorly हाँ या just a minute हाँ right तिथे exactly तेव्हा तिकडनं
This one.
नाही त्याच्या खालती जी दाखवली ना तू
Actually, ma'am,
Mahesh, that there is a mesentery on that. You need to remove that bone, then you'll see the anterior part. Yeah, that bone you need to take off.
yeah. Upper ठीक है. This one actually. This one. I hope I done all the thing on
So,
this side.
no, just go to that anterior portal again.
Yeah.
Yeah, and if you just raise that mucosa a bit, and yeah, that the anterior portal will be behind that. What you're seeing on top is probably some mesentery or a mucosal cover. Yeah, but that's okay. I mean, you need not expose it.
Yeah. State section.
You will also take the vulgarization stitch.
No, ma'am. I don't. I just suture the middle turbinate.
Suture the middle turbinate to.
To the septum on either side.
Okay.
Pairs. State section. How is it? Prayers देना. Section. That is left side sphenoid.
Yes, yes.
Done. Section. Prayers. एकत्रित verification. Section. Yes, Dhaku. Section. Wash. Pinoid should be just below this cell. I'm just trying to. This is only the cell and actual sphenoid is down there.
Down there, yes. Still down.
Actually. Sure, sir. Yes. Option. Yes. Option. Yeah, just enter the frontal sinus. Sphenoid, sorry.
Hello, sir. Harshal here.
Yeah, Harshal. Okay. అలాగే ball point. Hmm. So, in एक पेशंट है ना ते एनबीएम आउट काढून टाक. एनबीएम आउट काढून टाक लास्ट पेशंट उद्याच करू. हां. Action. Ball point पुन्हा. Total. Curate the नाही. Curate. This. Marshall, this is wide enough.
Yes, fair enough.
I have done all the thing on this side also.
Yes. Now the openings are fair enough.
Let me check with 70 degree.
Yes.
Hmm.
Deepak,
Curate the curate.
third section. Madam.
Yeah, but upper Jira 40 law, 40 rats law. Cover. Navigation. Action. Option. फिरत नाही. ठीक आहे नाही बरोबर नव्हतं मला. That is enough opening for frontal sinus.
Yes. There is one more cell, I think.
बेकस आपल्याकडून जिरा दिलं बेकस दिलं तरी चालेल. Suction. Register. Done. Oh. ठीक Okay, done. Pack, chala.
Nasal packing now.
नाही वाटत खरंच 0 डिग्री ते नाही वाटत. पेट सेक्शन नाही गरज. ठीक आहे चल दे. पॅक दे. Arshila, I'm going to pack now.
Yes, sir. Gondal sir is speaking.
Yeah,
अरे महेश, कॉंग्रॅच्युलेशन्स, छान केली सर्जरी तू.
thank you very much,
आणि
sir.
इट वॉज अ गुड इंटरॅक्शन.
Thank you to you also,
आणि
sir.
निखिल दवंगे, मी अजून बसलोय.
Yeah.
तर आम्हाला असं विचारायचं होतं, हे जे नॅव्हिगेटर तू लावतो,
Yes, sir.
ॲज अँड व्हेन रिक्वायर्ड ऑर कंटिन्युअसली ते अटॅच असतं?
सर कंटिन्युअसली अटॅच असतात. फक्त आपण प्रोब चेंज करत राहतो.
बरं बरं.
डिपेंड ऑन.
नाही, आम्ही तिघं आता सध्या आम्ही जवळच राहतो. आम्ही तिघं एकदा बघायला येऊ निवांत.
या सर नक्कीच.
नाही, नाही, I was under the impression that navigator is mainly for skull base and all that, but now face surgery is becoming more practical and more easy with this navigator.
Yes, sir. Definitely.
Uh,
I am using in all my cases of face. Sir.
yeah, you told me. And 2025 face with navigator, you must have done a better surgical job and better outcome.
Yes, sir.
बरोबर आहे ना? And that is the main professional satisfaction.
Yes, sir. Yes, sir.
Another thing, what I said long back, I don't remember the year, somewhere in 1992. Are you through surgery? No? We can talk, no?
Yes, sir. Yes, sir. Yes, sir.
Somewhere in 1992, Sandra Disa madam has organized one sinoscopy workshop. Some faculty had come from America. And
Yes, sir.
that time, nowhere in Bombay, nowhere in India also, that navigator machine was there. So he had imported that machine along with him just for conference purpose.
Okay.
But since 92, 91, 92 onwards, almost for 10, 12 years, it had not popularized. But I feel as the face surgery has increased and skull base is increased, and the navigator has become more and more popular.
Yes, sir.
No, but it was a good academic experience.
If we keep regular workshop for this navigation surgery, and it definitely the number of navigation will increase over a period of time. After my purchase, I think they have 3 to 4 purchase.
म्हणजे 3 to 4 only inquiries or they have purchased?
One in Aurangabad. Actually, already they purchased.
Okay.
Some few more in India also, sir.
Okay, that's good. Anyway, we enjoyed the workshop, good interaction, आणि छान केली तू सर्जरी.
Thank you very much, sir. Thank you for patient listening. Thanks to Medtronic people also for giving me opportunity. करून टाकायचं. ठीक आहे.
I think this is the last case for today, na?
Yeah, one more case is there. I am going to perform here. If you want to continue me, I will continue.
But there are no audience left now.
No problem. Then no, I have to finish that.
Okay, sir. Okay.
No problem.
Thank you, sir. Thank you, Sripad Hospital team, anesthesia team, OT assistant team. Thank you, everyone, and thanks to
Thank you to
Medtronic.
Sapna Kasliwal madam also, my anesthetics, regular
Yes,
anesthetics.
yes. Good part. There is a question to anesthetic team. What hypotensive agents you have used for these cases?
Yeah, madam.
Hello.
There is a question from audience.
Okay.
Any particular drug you use to lower the blood pressure, reduce
Yes.
the bleeding?
Now there is one drug dextromid is available. It is alpha 2 agonist, and it is very good for controlling blood pressure.
Yes.
And also I use NTG beta lock combination
Okay.
whenever required. Also we have
probe निघाला.
nahi. Hello.
Yes, ma'am. We can listen you.
And also we use propofol and isoflurane is there for us. So
Okay.
all these contribute for hypotension and good analgesia. All these are contributory factor.
Yes.
But especially if we want to lower the BP, we use dextromid and NTG.
Okay.
Thank you.
Thank you, ma'am.
Hello, Saurabh. Hello, Saurabh.
Hello. Hello.
हाँ Saurabh.
Yeah, Sushil.
Saurabh, any more cases are we demonstrating? No, nobody is there in the auditorium now.
No, we are done for today.
Done. I will pack up.
Yeah, please.
Okay, thanks.
Thank you.